right. Hello, folks. It's a nice full room today, which is a combination of you just got back from summer break, and we've got two varieties of health professionals in the room. We've got, I think mostly in the front are the PTs. Is that right? Is that what I have here? So the physical therapy students, and we've got the medical students. And during this particular course, the neuro part, the neuroanatomy part, is you guys are going to be merged. And so today's lab, not today's lab, this week's lab, there'll be an opportunity to get to know each other a little bit. And then during the weekly brain labs, you will be working together. An opportunity to do interprofessional, at least conversations, if nothing else. My name is Adrona Viknaviches. The fearless try to say it that way. The rest call me Dr. B. Dr. B is okay with me, all right? And I am, for those of you that are the second-year CPC students and second-year medical students, I'm the lead anatomist for all of your gross anatomy that's in the second year, which means really only one lab in neuro, because the brain labs, I don't run those, but all of EENT, and then when you get to OB-GYN. Okay, so we're going to a little bit in the beginning of the course or the year, and then a whole bunch in a little while afterwards. My job today is to set you up with some foundational information so that Wednesday's gross anatomy lab will make a lot more sense for you. But also, even if there wasn't a lab, we want to have some sense of what's happening intracranially. Most of you have done a lot of anatomy up to this point that didn't involve the head and neck to a large extent. So to get you started thinking in that direction. But before we go into the head, I want to start, and here's my general overview: cranial cavity, spinal canal contents, meninges, arterial supply, venous drainage, and the ventricular anatomy and CSF. So, before we get into the skull, because it's extraordinarily complicated as a skeletal structure, let's go and look at something that you know inside out and upside down. This is the distal end of a femur, and obviously it's been longitudinally sectioned. And one of the things you'll remember is that at the outside of bone is this dense type of bone called cortical bone. And every bony structure you have in your body has to have a connective tissue covering on it. And so the connective tissue covering on the outside of cortical bone, regardless of what kind of bone it is, but in this case it's a femur, is this stuff called periosteum. Okay? Inside, between those cortical plates, there's a bunch of cancellous bone or spongy bone, and it's bone also. So it needs to have a connective tissue protection around it. And to distinguish it from the outside stuff, we call the inside connective tissue endosteum. Pretty easy when you're thinking about a limb bone, okay? Now let's switch over to a skull. So we're just here in the corner. This is some guy who got a nail in his eye, whatever. I had to have a picture of a skull, so there. So I'm just zooming into this part of the calvarium and zooming in to show you this sort of what looks like a section, a sagittal section through the skull. And there's a lot of parallels with that femur that we were looking at before. There's cortical bone on the outside. You see a cortical bone that we call the outer table. There's a cortical bone thing on the inside. We'll call that the inner table. It's also called lamina table, lamina. And between the two cortical bone tables is what's an X, is the cancellous bone. And it's called something fancy in the skull. It's called a diplo. Okay? So let's just do a thought process. And we're going to use those audience reply devices. And I'm going to give you a short period of time to answer. Those of you that answer quick are going to know if you've got it right or wrong, and the other ones are just guessing. Okay? So let's look at this particular cross-section. What connective tissue lines the diplo, that's the cancellous bone, and the inner surfaces of the cortical tables, meaning the inside, the side of the cortical table that faces the diplo? Is it going to be periosteum or endosteum? Okay? Enough clicks. I'm happy. And more people said endosteum than periosteum, and that's correct. So anything that has cancellous bone associated with it is going to have endosteum there. Okay? So let's try it again. Next question. What's the connective tissue that's going to line the outer surface of the inner and outer table? That'll be all the way out here, and that's the outside of the skull. And then on the inside of the skull, what lines that? Is it going to be periosteum or endosteum? A couple more clicks. Make me happy. Yeah, people just dropping those things on the table and going, that's good enough. Okay. Oops, go back. And the answer, polling closed, but there's no response. The answer is periosteum, okay? It didn't show it. So the answer is periosteum. And oh, there we go. So anything that's the next slide here, the periosteum is going to be on the outside of the outer table. It's going to line the inside, the inner aspect of the inner table, and endosteum is going to line everything that's in the cancellous bone. The reason why I make a point about this is because you think of the inside of the skull, well, that's probably like where the cancellous bone is, right? And it's like, no, it's cortical bone line, so it has to have periosteum on it. The fancy thing when you get to, oh, and I should say that the periosteum on the outside of the skull is going to be continuous with the periosteum of the inner surface of the skull, wherever you have a suture, wherever you have a foramen or a canal. Okay? So those canals, suture, they're going to have periosteum. It's going to slide through and be continuous with the inside of the skull. Now, if we start being more specific about it being a cranial tissue, what we'll see is that you could call the outside periosteum the inside periosteum. Some physicians prefer to call the outside periosteum pericranium and the inner one the endocranium. So there's actually special names for the inner and outer periosteums. And the outer periosteum, or the pericranium, is just like periosteum everywhere else in your body. It's stuck to the bone. It's really hard to peel off, okay? But that's not so true for the inner periosteum. That endocranium here, it's actually fairly loosely attached to the bone. The places where it's stuck real strongly is anywhere where there's a suture, a canal, or a fissure, or something like that. So it actually isn't adherent to the bone at all in most places. Sounds like a lot of detail. You're thinking, why is she going into this? But it has clear and important anatomical and clinical importance to it. So let's go down. You know, the central nervous system includes the brain and the spinal cord. And we know that you have these layers of connective tissue that surround these structures, okay? And I'm going to, let's see, I was going to wear a sweater of a different color, but I forgot it, but somebody kindly left a plastic bag. So I have 3 layers of meninges of connective tissue on my arm. This outermost thing, it's pretty tough, is my dura, okay? The next layer that's deep to it is going to be what? It's going to be arachnoid. Everybody good with that? Where's my 3rd layer? It's my skin. You can't peel it off, okay? So there is no space underneath the pia. So you think of the 3 layers. The innermost layer is fused to the central nervous system, whether it's the spinal cord or the brain, okay? So we've got the 3 layers of meninges. We've got this periosteum that we've been talking about. What's the relationship between these structures? So let's start down here. So this is showing, this is the brain up here, and this is an abbreviated version of a spinal cord. These are all spinal nerves coming out. And it's zooming in on this spot right here as you come down, okay, right there. So you have, this is part of the spinal cord. This is a vertebra with some intervertebral ligaments. And then what it shows is that there's a space. And the next thing you see is a pretty tough structure, and that's the dura. And right opposing the dura is this red line, and that's going to be your arachnoid. And then the pia, like we said, is attached to the spinal cord over here. But in the area of the spinal canal, every once in a while, some pia comes off and forms a little tethering structure called a denticulate ligament. And so denticulate ligaments are just pia that pull off to the side, and it helps to stabilize where the spinal cord is from right to left, up and down. So that should sound familiar from when you did vertebral canal dissections. Now let's take a look at this area here. This is where it's cut through the cerebrum, right there. We're going to take a quick peek right here, zoom into that. So what we're expecting bone on the outside, so we see some skull. That's that white line, that white zone. On the innermost, we expect to see brain. That's in fact what we have. Between everybody, we're expecting to see layers of connective tissue. So you see skull, you see dura, you see the red line, which is arachnoid, and then you have pia. Don't see a space between skull and dura over here. I'm going to go even higher in this cross-section, all the way at the top where the sagittal suture is. And I see my skull on the outside. I see my two cerebral hemispheres. I see this thick thing called dura that's doing something funny, but there's my dura. There's this red stuff, that's my arachnoid, and I know that my pia is attached to the brain. But what is it with this dura? What in the world is going on? In fact, what's going on is, if we take a closer look at it, is that the dura up in the skull is actually, the meninges that we call the dura, is fused with the periosteum. And so that's why it looks so thick, okay? So the periosteum, the inner periosteum or that endocranium, is always going to be close to the bone. It may not be stuck very tight to it, okay? But it's also, in many places, going to be fused with the true dura, the meningeal layer. So when you're talking about dura in the skull, it's actually a bilayer fused together in most places. The outermost layer is the periosteum. The innermost layer is the actual meningeal. Okay? And that meningeal layer is going to be the same meningeal layer that we see in the spinal cord area. And we'll talk about why, what's with this blue area, it's a dural venous sinus. We're going to go into that in much more detail later. Okay? Everybody okay with me? I talk fast, but that's the way it goes. So we compare the spinal meninges and the cranial meninges. When you talk about the dura, the spinal meninges are just the real dura, the meningeal layer of the dura, single layered. But when you get to the cranial meninges, that single layer of the meningeal layer fuses with the periosteum on the inside of the skull. So it's a double layer. Okay? The arachnoid in the spinal canal is pretty much the same as you see it in the skull, except, oops, I didn't point this out, every so often in these places where you see these dural venous sinuses, the arachnoid, which is this red stuff, pokes through the dura and forms these little projections that we call arachnoid villi, which have to do with reabsorbing cerebral spinal fluid. And we'll talk more about that a little bit later. So we do have a little bit of a difference when you get to the cranial meninges. For the arachnoids, rather the arachnoid mater, there are these things called arachnoid villi that you don't see in the spinal canal. And then finally, the pia is going to be attached to the central nervous system. It really doesn't matter if it's the brain or the spinal cord, but you are going to have little projections attaching laterally in the denticulate ligaments. And once you get past the conus medullaris, there's going to be the filum terminalis. That's just the end of the pia, tethering itself down to the base of the vertebral column. Okay? So there are some significant differences. And these significant differences are going to be reflected for you in the spaces that they create or don't create, because that's where you're going to find hematomas occurring and things like that. So what are the spaces? Okay, if we go back to this picture over here where we're in this the vertebral canal right here, I told you that we had the vertebrae here, the intervertebral ligaments. Here we have dura, and there's a big space. And actually, the periosteum is attached to, just like on the femur, the periosteum is going to be attached to the vertebrae over here. It's not attached to the dura in the vertebral area. So clearly there's a space between where the bone is and where the dura is, and it's called the epidural space. Are we going to expect to see similar kinds of spaces up here? Well, let's go through this as a practice together. And so I'm going to get this out of live mode for a second. I'm going to fill this out, and you guys can follow along. And you're going to help me fill this out. Let's see. I don't want to ruin anything. If we're in the vertebral canal, is there a space between the vertebrae and the periosteum? Yes or no? The vertebrae is just like a femur. The periosteum, is it stuck like you wouldn't believe to the femur? Yes, okay? So we could basically say there's not going to be There's no space there at all. So I'm going to get rid of that line because it's fused, all right? In the vertebral canal, is there a space between that fused periosteum on the vertebrae and the dura? Yeah, we called it the epidural space, right? That makes sense? So we could say there really is a space here. And that's the epidural space. Oops, epidural. It'd be better if I could type. Okay? Is there a space between the dura and the arachnoid? Do you guys, it doesn't have to be, it could be a potential space, meaning that if you leaked fluid into it, it would create a space. Is the dura fused to the arachnoid? The answer is no. The only reason why they're stuck to each other is because of the internal pressure that pushes the arachnoid against the dura. Okay? So we would call this space the subdural space. I love these names because they actually make sense, right? But we're going to say that it's a potential space because it actually normally wouldn't be much of a space. Okay? Is there a space between your arachnoid and pia? Yes. It's filled with cerebrospinal fluid, right? What do we call that space? Subarachnoid space. So we've got something there. Cool. Is it subarachnoid space? You know what I'm trying to spell here. Okay. Is it a real space? Yes, because it's filled with cerebrospinal fluid. Is there a space between the pia and the spinal cord? Is there a space between my skin and the rest of my arm? No. So we could just get rid of that. So now we know for the vertebral column and its contents within the canal where there's potential spaces and where there's not, right? So let's try to do the same thing for the cranial. So you got the skull. The next layer is going to be your periosteum, that endocranium. What did we say about that? Is it fused tightly or not tightly? Not tightly, right? So we might want to call this an epidural space, but the problem with that is that an epidural space should be superficial to the meningeal part of the dura, and we know that the meningeal, you stay there, buddy. We know that the meningeal part of the dura and the periosteum are fused. So if we're going to name this, I'm going to call it an extradural space, but I'm going to have to be honest with you, is that you're going to hear it called by some people an epidural space. But it really isn't because it's between bone and periosteum. It's not between periosteum and dura. Okay? Is there a potential space between the meningeal part of the cranial dura and the arachnoid? You bet. It's the same thing that we had over here, the subdural space, which is a potential space. Copy. Okay. Is there a space between the arachnoid and pia? You bet. Same space as we had before. It's a subarachnoid space, and just as it was before, it contains cerebral spinal fluid. And there's no space between my pia, and it shouldn't say spinal cord here. Sorry about that. It should say brain. Okay? So there are three spaces when we're below the neck and three spaces within the head. The two innermost spaces are the same. Subarachnoid space, subdural space, they actually are continuous with each other. But that epidural space and the thing that we're going to call an extradural space are very different. And they're not continuous with one another. Okay? Everybody with me? Good. No one's brave enough to say that they didn't get it. All right. So let's now take a look at the content of these spaces. Okay? So what I've done right here is I'm showing you a slide where all that's been taken off is a piece of the calvarium, the bone itself. Remember, the calvarium is not tightly fused to the periosteum. So what you're actually looking at is the periosteal layer of the dura right now. And you're seeing vessels traveling through it. Those are the meningeal vessels that are sandwiched between the two layers of dura. Okay? The one that's going to be the most important for you to remember from today's lecture is this one right here, which is your middle meningeal artery and vein. So let's go back for a second. So we know that we've got these vessels, and let's just talk about the artery, okay? We know that they are sandwiched between the periosteal and the meningeal layer of dura. Let's say you have a break in the skull, you have a crack in the skull that tears one of these vessels. Where is the bleeding going to go? Where is blood going to extravasate? Is it going to go between the calvarium and the periosteal layer of the dura? Is it going to go between the two layers of dura? Between the meningeal layer of dura and the arachnoid, or between the arachnoid and the pia? Where will the middle meningeal vessel spill its blood if it's broken, usually because of a fracture of the skull? Let's see what you guys thought. We have more people responding periosteal and meningeal layers of the dura. That's going to be hard. And the reason why it's hard to spill blood there is because the two layers of dura, the periosteum and the meningeal layers, are fused together. So even though those vessels are traveling in there, as they bleed, they're not going to be able to actually split the layers apart. Okay? So that's the wrong answer. The second most beloved answer was the first one, and that's the right one. It's going to be between the calvarium and the periosteal layer. Why? You have a break in the skull. It's going to tear the periosteal layer a little bit, and in the process, shear that vessel. So the blood's going to go outwards into that space, because the periosteum is not attached very tightly. What is that called? And by the way, this is never going to be a great answer. I'm going to give you a hint right now. This, spilling something between the arachnoid and pia, is like spilling something between my skin that's attached to the rest of my arm. There's no space there, okay? So let's take a look at a picture or two so you can understand the answer here. So if you have something, so this is just a series of CT scans, obviously transverse, and on what's shown in the red all through here is where the dura is. Well, actually, if I go back by 2, that might be a better way of doing it. If I go back. So if there was a crack in the bone right here and it nicked that vessel right there, one of the branches of the middle meningeal, that means if that thing got nicked, that periosteum got nicked and the wall of the meningeal vessel got nicked. It's going to spill blood towards the bone. That's the direction that it's going to spill blood. And so we're going to call that, because of the space that we identified before, we're going to call that the fake epidural. There should be quotes around it. It really is an extradural hematoma. I don't like using epidural here because there is no real epidural space in the skull. But you'll read it in the literature as being called epidural. Okay? So it's an extradural